local GP, have been for, gosh, 26 years. I've always had a special interest in women's health and really looking forward to the session today. It's hopefully going to be a really practical one, lots of images for you and lots of discussion and ability for us to talk together about what we see day to day and those conundrums that we find ourselves up against. So please put lots of questions in the chat. We'll come to as many as we can at regular opportunities throughout the presentation. And I'll hand over to Carly.
Hi everybody, I'm Carly. I'm a clinical practice nurse. I have been for 5 years and a general registered nurse for 16 years now. I'm in the same situation as all you guys, doing smears very regularly, seeing lots of different cervixes, and often find myself in the position where you think, where do I go with this? So that's the whole point of this, is hopefully answering all your questions. And like I said, we weren't expecting as many people as we've actually got. So we will try and get to as many questions as we possibly can. And if not, we'll get back to you.
Right, I'm just going to share my screen and we'll get the presentation up and we'll make a start. Fantastic. So, as I said, what we want to look at today is a really practical session. We're focusing on the appearance of the cervix. So to help us to be able to identify the worrying cervix, we need to be really confident about what's normal. So we're going to spend quite a bit of time looking at what's normal and also some of those really common benign conditions that we see all the time, but sometimes can look quite worrying. So we're going to really look at the polyps, look at the ectropions and think about, what we're going to do, how we're going to assess that appearance of the cervix to help us know when to worry and when we don't need to worry. So we'll also have a good look at remedy guidelines along the way. Some of these are being updated at the moment, but I've been part of those updates as part of the Women's Health Programme. So I'll be able to share with you what the thoughts are around that. And we'll signpost you to lots of useful resources for next steps as well, in case this triggers you to do a little bit more. So,
Sam, just to interrupt, somebody said that they can't see the presentation. Can I just confirm that everyone else can see the presentation?
I can see it on my side.
Right.
Yeah, they can see it. That's fine.
Thanks.
Sorry, Jackie, that will be you.
Great, that's really good to know. Thanks, everybody. So this is an important topic because cervical cancer is rare. Many of us won't see it. We will look at many, many different cervixes doing screening, and we may never see a single case of cervical cancer. So we may not have that experience of having identified one in the flesh. Cervical cancer is the 14th most common cancer in women in the UK, and there are around 3,300 diagnoses each year. We know that one of our 2-week wait referral criteria is for an appearance of the cervix consistent with cancer. And of the referrals that go through to gynae under the urgent care pathway for query cancer, around 25% of these referrals are for a concern in the appearance of the cervix. Thankfully, the vast majority are not cancer, but the pickup rate is only around 2%. So around 98% of the women that we're referring through with a concern over the appearance of the cervix won't have cancer. And of course, it's really important if we're worried that we're able to refer, and we will never be looking for a referral rate to be exactly all of just those cases of cancer. There will always be lots of negatives. But there's a source of real anxiety, isn't there, for women if they're being referred under this pathway. So one of the aims of today really is to help us think about what's normal and all of those variations of normal, to help our confidence in thinking about those referrals that we need to send through. So I'm going to share lots of pictures today that are taken from the cervix chart, a chart that I'm sure is familiar to very many of you from the cervical screening training. So that lovely table of pictures, different images. And of course, pictures that we see on slides, again, when we're doing an examination, it's different, isn't it? We often don't have images just like this, so these are helpful, but again, we need to think about our confidence and competence in our practice as well. So, as with every part of the body, there's a lot of variation in normal. And over time, when we see lots of different cervixes on examination, we'll see this big variation in normal. A simple difference here between the null ipsos and the multi-ipsos, so something that we'll get used to seeing quite early on. I remember at med school, the multi-ipsos being described to me like a smile, that sort of crescent shape. The normal cervix will be smooth. It will be regular. It won't be ulcerated. There isn't usually contact bleeding, but we'll come back to talking and thinking about that a bit more later on. But of course, there can be a huge variation in normal. And I think that's always our starting point, isn't it? Is thinking, right, am I confident in identifying normal? And as part of normal, very commonly, we can see these, which are known as Nabothean follicles, also known as Nabothean cysts, sometimes called epithelial inclusion cysts or a retention cyst, lots of different names for the same appearance. Essentially, for me, these are just a bit like spots. And if I'm describing them to a patient, that's the type of analogy that I would use. They're a gland that's been blocked with mucus, and you get this appearance, a bit like a spot. They're really common. Sometimes you'll see just one. Other times you might see 10 or even 20. They can be quite small, so maybe just 0.5 centimetre. They can be quite a bit larger, sort of 1.5 centimetres. And their appearance can vary in colour too. They might be white or a kind of light yellow. They always tend to be smooth. So again, coming back to that normal cervix, it's smooth. It will feel soft if you were to touch it with a finger. And these are completely normal. They're harmless. They're not precancerous. They're not linked with kind of polyps or anything. They don't need any treatment. So they'll be asymptomatic. The person themselves won't know they've got them. They won't be able to feel them with sex, won't be able to feel them with using a tampon or a cup. Just a completely normal finding.
And I think on the Ardens template, when we're filling out our paperwork, it does just have one option. I believe it's Nabothean follicles, but you can describe it however you like, free text as well, whatever you kind of describe it as yourself.
Yeah, great. Thanks, Carly. That's really useful. It's great to think about these practical applications. What do we do? How do we, describe what we've seen? So these are images from the cervix chart of cervical cancer. Going to come to these now and then go through lots of the benign conditions. Now, I think all of us, if we saw this, would think, not quite so happy with this. This doesn't look right. Even if we're not confident as to what we're seeing, we can clearly see that this looks very different to those previous images. So instead of that smooth, regular cervix, this cervix is raised in places. It's very irregular. It's going to feel very different. And as a GP, I always tend to feel the cervix before I pass a speculum as part of how I've been trained. And if I were to feel this, it's going to feel hard and craggy and kind of nodular. This is going to bleed if we touch it. So if there's any contact with this cervix, it's going to be what we describe as friable. It's going to bleed to just a light touch. And there may well be areas of ulceration that we can see. And this person may have had quite a lot of discharge. There may be a smell to that discharge. They may have been experiencing changes in their bleeding patterns, so postcoital bleeding or intermenstrual bleeding, bleeding between the periods. They may have postmenopausal bleeding, depending on their age. They may get backache. They may find sex is painful. So there could be a number of different things in in their history that would also point us towards there being something more concerning. And so just think for a moment, if this was the appearance that you saw when you came to do your routine screening, there'd probably be a moment of panic, wouldn't there? You'd be thinking, oh gosh, this could be cancer. And I think quite often when we're doing screening type of tests, we get used to things being normal a lot of the time, and our patter that we might say to patients often reflects that reassurance that we want to give. So we're going to need to just think for a moment, what are we going to say to the patient? What are we going to do? Do we feel confident that we know this needs a 2-week wait referral? Do we feel we need a second opinion to ask somebody else, actually, what do I do here? I've seen something that really worries me. Do I get a GP to review it? Do I still take the smear? Do I take some swabs? What's the course of action going to be? And you're really welcome to post your thoughts in the chat if you'd like to, kind of as we go along. So, as we said earlier, one of our 2-week wait referral criteria is an appearance of the cervix consistent with cervical cancer. So if we see an appearance like that, it is absolutely appropriate for us just to refer if we feel that it's within our competence and confidence to be able to do so. We don't want to delay these people too much. So if we did think that we wanted a second opinion from a GP colleague, from an ANP colleague, we would want that ideally to happen pretty quickly, because we want to get this person through to specialist care as soon as possible. Any thoughts that anybody's posted in the chat there, Carly, around that, or anything we've covered so far?
Not at present.
So do feel free to kind of drop things in the chat, reflections on what we've talked about, if there's anything you want us to expand on, and I'll have these slides regularly through the presentation so we can pick up on any queries as we go. So
Sam, we just got one question through. Any examples of what very early cervical cancer would look like?
Yeah, I think that's such a good question, because it's when things are really advanced, it's much more obvious, isn't it? As with anything, in the early stages, it can be harder. Of course, it might be much more subtle. It may not be as dramatic as those pictures that we saw. So if we come back to the slide here, we can see that the whole of both of those images are looking really abnormal. I've only seen cervical cancer twice. Both times it was quite advanced. It did look quite like this, and both times the person hadn't been examined for a long while before that. It may be that you're seeing changes in just one area and it hasn't developed all of the way around. As ever, there's quite a kind of spectrum of different appearances, isn't there, in terms of what you're seeing? Great. So I'm going to take you back now across to thinking about the ectropion. So common and can be quite a worry for us, can't they? Because again, just with these two images here, we've got the one on the left that looks quite regular. It's got a nice edge around the ectropion, but the image on the right actually potentially could be a bit more concerning. You've still got quite a clear, well demarcated edge, but areas within the ectropion that look a little bit different, look a little bit irregular. And you can see some bleeding there, some contact bleeding. So this could well worry you, and legitimately so. Ectropions are really common. And again, the patient may well have experienced a change in her bleeding pattern. She may have had some intermenstrual bleeding, some postcoital bleeding, or again, some postmenopausal bleeding. And again, there may be a vaginal discharge. So that history isn't necessarily going to help us particularly to differentiate. If I were to feel this cervix, this is going to feel soft. It's not going to feel hard and craggy and raised like the cancer that we saw images of earlier. So although this may look irregular in places, it's not going to feel it. So again, as a GP, that's helpful for me in terms of my assessment. And ectropions are related to estrogen, which I think is helpful for us to know. So ectropions are really common at puberty and in pregnancy, not times that we're taking lots of cervical screens, but they're also really common with the combined pill and with HRT, and particularly mid-cycle when our estrogen levels are higher, so when we're ovulating. And often that's the time that we get people in, isn't it, for a screen, kind of mid-cycle. So we know that they can be more apparent, more obvious, relating to higher estrogen levels. You can examine somebody a couple of weeks later and it can look quite different. So it can change. And in terms of how I would describe this to a patient, I often use the analogy of skin like around the mouth. I tend to say, well, usually the skin on the outside of the cervix is more like the skin on the outside of our cheek, and the skin on the inside more like the skin on the inside of the mouth. And with an ectropion, it's a bit like the skin on the inside comes to the outside, and then it's not quite as robust. It's more likely to bleed when something comes into contact with it, whether that's during penetration with sex or whether it's at a cervical screen, for example. So in terms of what we're going to do, well, it depends on our worry level, doesn't it? This is what Remedy says at the moment. So it says that we don't need to refer those people who are asymptomatic, where we might just see an ectropion by chance at a screen and they've got an in-date negative screen. We don't need to refer them. We should consider referring if we're worried. So if the woman is aged 35 or over with a change in her bleeding pattern, you can see here where an ectropion is visualized, which does not have suspicious features. Consider other causes like the pill. Have a low threshold for referral if you have any concerns. Tricky. And, you know, some of us may be concerned with some examinations, other of us may not be, depending on our experience. So our own clinical practice comes into play here. You may feel that particularly if you're starting out on taking cervical screens, this is the sort of time where you really want that second opinion, want to sort of ask somebody else to have a look. And for example, if your patient is on the pill, and is happy to come off the pill and go on to a non-estrogen containing contraceptive method, the ectropion can go, it can disappear. So it can be there and be bleeding and causing symptoms potentially, and a few months later, be gone. So it is something that can change. So sometimes a second examination can be appropriate to see if things have kind of evolved. So the approach is going to depend on our worry level, on the story, on how worried the patient is, sometimes too, and on whether it's been symptomatic. And ectropions can potentially be cauterized. So when we're referring people, sometimes the main idea of our referral is to exclude cancer. That can be quite appropriate in some situations if it's got worrying features. It may be that we're looking to see, can there be a treatment option offered for that patient? And cautery can be done, but actually if that person is still on the combined pill with lots of estrogen, then it's just likely to come back again. So it's not an effective longer term treatment option, which again, I think is important that we're open and honest about it and kind of share with people in terms of their expectation, that they could sit on a wait list for quite some time, have that cautery done, and 3 months later be back in the same boat as they were at the beginning. Locally, in terms of our referral pathways, UHBW tend to see people in gynae clinic for any concern about the appearance of the cervix, and NBT tend to see people in colposcopy. So there's slightly different approaches from our trusts locally. and the kind of new remedy guideline coming through is just going to help clarify that a little bit in terms of the referral pathways. So the draft guidance at the moment suggests for NBT referring through to colposcopy and for UHBW referring through to gynae. Probably one of the other most common conditions that we see are cervical polyps. So they're found in up to about 4% of women, so really quite common. They're almost always benign, thankfully, and they can arise at the cervix itself, or they can sometimes be endocervical and then kind of come through the os and be on a little stalk. And usually, again, they're asymptomatic. Usually people won't know they've got one, but they can be a source of bleeding potentially. And again, from these pictures, you can see the colour can vary, the appearance can vary, they can vary in size, they can vary in shape. Sometimes you can see the base of them and kind of be able to tell how big they are. Sometimes you can't. And as a GP, I've removed many of these in primary care. It's quite straightforward to remove them. I always send them to the lab for histology to double check that, as I said, they are almost always benign. So again, have a little think. What would you do about a polyp if you saw one? What's your practice? What happens in your own surgery if you see a polyp? Again, this is a link from Remedy. This is currently what the Remedy guidelines say. And again, it differentiates between whether a polyp is symptomatic or asymptomatic. So for our purposes, if we're doing a cervical screening and we come across a polyp, usually it's an asymptomatic one that we found by chance. And here in our guidelines, it's saying that for these asymptomatic polyps, if they're just found incidentally, we don't need to think about referring people unless a GP is concerned by its appearance. So suggesting that if a practice nurse finds an asymptomatic incidental polyp, should be potentially asking a GP to review that person and to do an examination. And if the GP has any suspicions of malignancy, then potentially to refer on. And some GPs will be happy to remove polyps if you can see the base of the polyp and the size of that polyp is below about sort of 1.5 to 2 centimetres, it's usually safe to remove them. If you can't see the base, there's always a concern that they might be quite a bit larger than you might think. And if the base is wide, the blood supply sometimes can be quite significant. And so you can end up with a situation that's quite tricky then to manage in your GP consulting room. So the GP, if they're happy to, can just twist them off in practice and send them. Now, again, chatting with gynae colleagues when we were looking at updating some of the Remedy Women's Health guidelines, they were certainly of the view that they would never see somebody in clinic with a polyp and not remove it. A bit like I think as, if we send somebody with a headache through to a neurologist, they always get a scan, yet we're always being encouraged not to scan people with headaches. And the gynecologist really sort of said, if we saw one, we would remove it. Yes, we're confident that they're virtually always benign, but if we saw it, we would remove it and check. So again, useful and be really interesting potentially for all of you here today to compare what people do, what your kind of pathways are within your practice, whether you send people through to a GP for another opinion. There'll be different practices that are doing things in different ways. So do feel free to share on the chat. It'd be useful to see. And we can again talk about that when we come to questions in a moment.
We've got somebody saying about do we take the smear if not occluded and then refer to GP? If you find one on examination, do you still take the smear or refer to COLP first? But obviously you've discussed if it's not worrisome, then you don't necessarily need to refer if there's no symptoms. But remember, if it is removed by the GP before your smear is taken, you need to wait further 12 weeks before you try and do the smear sample.
Yeah, Yeah, absolutely. Thank you. Yeah, that's really helpful. And I think, again, it's going to come down to whether you feel confident, whether you have seen a cervix and think, that's a polyp, I know what that is, and I'm happy that I know one of my GP colleagues will see this and sort it for me. Great. If you look at that cervix and think, well, it doesn't look right, but I don't know why, again, you're probably going to want somebody else to take a look. I absolutely agree. If the cervix isn't occluded, I would take the smear and then chat with one of your colleagues and think about the next steps from there. Thank you.
So it's a good option as well to look back on the notes, see if it's been reported on in the past or if it's the first presentation. Sometimes, obviously, patients will be aware that that's something's been discussed with them.
Yeah,
so that's
right.
To have a discussion.
Yeah.
Somebody's referred all polyps to GP for removal or review, so that's good. Different takes on things.
Yeah, we'll all do things slightly differently, and I think GPs will as well with polyps. So there will be a wide range of practice, and there's not necessarily a right way or a wrong way. Again, they can sometimes disappear. So it might have been reported on before, and then there might be another examination where it's not been seen, particularly if it's on a stalk, then it can come through the cervix and go back again sometimes. So it's, again, tricksy sometimes. It's not always consistent that you'll find it every single time.
You've got somebody new to smear taking, saw a polyp, got a colleague to review, booked in for GP review, but first appointment was not until the 30th of June. You're asking if it should be seen sooner, but it all depends on the history, really, as Sam said, if there's any abnormal bleeding, if you're concerned if it's large. But if she's not presented with this herself, then you'll probably find that there's probably not much worry from the patient's perspective, and June 30th it should be okay unless they're concerned. Yeah, I would absolutely agree. I wouldn't see polyps as being as something worrisome that needs a review quickly. But again, the key is how confident you are that that's a polyp. So if you've identified it's abnormal, but you don't know why it's abnormal, and it could be cancer abnormal. So I suppose it again comes down to thinking about how confident you are about what you're seeing. And often they're classical, they look really like these pictures. If they didn't and there was a worrying story, then potentially, I suppose, talking to your supervisor and chatting it through and thinking, does this sound like it can wait till the 30th, or should I be getting this person seen sooner? Warts are less common, but again, sometimes can be tricky because they can look a little bit irregular. So cervical warts, they can have this appearance. On the left, we would describe it as kind of filiform, like these little kind of villi. On the right, it looks a little bit more irregular. Sometimes they look like little cauliflowers, I often think. They can have different appearances. So warts are caused by the HPV virus, but usually a different type to the types that we're screening for. We know they're more common if people smoke and if their immune system's suppressed. And just like with any warts, anogenital warts, our treatment is largely cosmetic. It can't shift the wart virus. So with cervical warts, again, very often they're not treated. They can be potentially, and again, if somebody's immunosuppressed and has a huge number of them, on occasion the sexual health team will treat them. And there's, again, often spontaneous regression. They can just go away in the same way that warts can on hands and feet and elsewhere. Encouraging people to stop smoking if they smoke can be really helpful for that. I think these are tricky. Patients can get really distressed by the idea of them, and especially then if we suggest that there isn't any treatment required as well. So again, it's an area where our consultation skills can be very important in terms of kind of really talking to people about what we've seen and reassuring them that there's no harm from this wart and it's not going to affect things for them moving forwards. This again is taken from Remedy, so trying to kind of link you to our local guidance for all of these different areas. And again, just get you to reflect for a minute on what would you do. So if you saw a wart, how confident would you be about
knowing that was what it was? How confident would you be about talking to the patient about it? Would you know what to do? So this is a little flow chart that's come from Remedy that's asking if somebody's a smoker, thinking about their age, and really just encouraging us to take that screen. If warts haven't been known before, again, sort of talking with that person, you might want to offer an STI screen, especially if that hasn't been done recently. But routine treatment isn't necessarily recommended for these.
We've got a question about infecting sexual partners with the warts.
With the warts. Yeah,
Yeah.
so the wart virus is incredibly common. And skin to skin contact can transmit the virus. So it doesn't need to be penetrative sex. Any of us who have ever had sex have been in contact with the wart virus. It's everywhere. So even if you've used a condom, every time you've had sex, you can still be infected with the wart virus. So pragmatically, actually, this is not something that needs to be high on our worry list in terms of kind of contact tracing and things, because it is just everywhere. And hopefully with kind of the immunization programs and things, if that gets rolled out further and if more strains are vaccinated against, it could be something that we see become much less common in the future. But the wart virus is very, very common. So the STI screen is more thinking about other things, really, just that opportunistic chance as you're talking about this to do a screen for other things.
And we've got the other question of the left picture of the wart obstructs the os. Can you still take the smear?
Yeah, it looks like it might do, doesn't it? But probably I expect the os is just sort of underneath that area. So you may still find that you can take it. Again, that's always the trouble with the pictures, isn't it? They don't give you that real life appearance. And you may find that with a little swab or something that you can kind of lift up and still take the smear. I think it would depend on how things were actually in real life. What do you think, Carly?
Yeah, absolutely. And it's difficult because if we're not doing anything to remove the wart because it is purely cosmetic, then that's where we kind of stick with, okay, we still need to do the smear, but the wart doesn't need to be removed. It's just trying to get to the best of a bad situation, really.
Yeah, exactly.
And then we've got two questions going back to polyps. Is it usual for a polyp to have contact bleeding?
They don't usually bleed on contact polyps. The surface of them usually won't bleed. They can, of course, and especially if somebody has atrophic changes, then they could bleed, but typically they don't.
And then if someone has a polyp, do we take the smear if we can't see all of the transformation zone?
If we can't see all, yeah, that's harder, isn't it?
Yeah, absolutely.
I think that's really tricky. So, in that situation, you may want to, if you have got a GP in the practice who's happy to remove it, and it looks like a typical polyp, you may want to think about the removal first and then the screen potentially. Again, I expect different people will do different things in that situation. And it's going to depend on your colleagues probably too.
Would you do a referral to colposcopy if the polyp has got contact bleeding?
Not just because it had contact bleeding. No, if it was a typical polyp and I was happy it was a typical polyp, contact bleeding would be still asymptomatic probably for the patient unless they're getting bleeding with sex potentially, which could be then a symptom for them. But if it's contact bleeding purely from our investigation and it's a classical polyp without any worrying features, I wouldn't say that on its own necessitated referral. Again, coming back to the Remedy guideline kind of about polyps, it's differentiating whether they're symptomatic or asymptomatic and thinking about any kind of worrying signs from them. So that's our referral pathway.
Perfect.
Well done. These are all great questions. And I'm sure other people are all thinking the same thing. So keep them coming. It's absolutely brilliant just to kind of have one of these real life examples of actually what do we do with this? This is unfortunately quite common, isn't it? We see this quite a lot, kind of signs of atrophic changes. Completely preventable with some local estrogen if the person is safe to take it, which the vast majority of women are. And this examination may have been very, very painful for this patient. And I think it's really important we acknowledge that. And, you know, unless they've got breast cancer and they're on an aromatase inhibitor, I'd be strongly supportive of encouraging them to use local estrogen forever, but particularly for the next screening if they're due to have another one. So, you know, kind of really talking around this, talking around the safety of local estrogen and remembering that we can see this appearance not only in women who are postmenopausal, but also in women who are breastfeeding, women who are using depot, and also in trans men, particularly using testosterone. I don't know if any of you were able to come on our Women's Health Day, but we ran a great skill session with a trans male actor, a guy called Andy. And we did this great role play where we were trying to talk about vaginal discharge without using gendered terms. And Andy was encouraging us to talk about front hole irritation for kind of asking about atrophic changes. And really encouraging professionals to offer local estrogen because it's not well known for the trans community that this can be a safe option to use alongside testosterone. And because that it's, you know, that it's very much locally absorbed, we're not going to see any systemic changes from that tiny, tiny dose of local estrogen. So, yeah, and it, you know, a good one to kind of think about, a very very common condition that is very, very easy to treat with local estrogen, which of course is now available over the counter too, which is great for postmenopausal women.
We've got a question about how long before you do the smear do you need to stop the topical estrogen? I believe I was taught 48, 72 hours, so a good kind of 2 to 3 days.
Yeah, that's right. And usually with local estrogen, you kind of use a loading dose at the beginning of treatment for a good kind of 2 weeks. But in this sort of case, up to 4 weeks or so, sometimes longer will be needed to kind of really help things settle. So you might be encouraging that person to use the local estrogen daily for up to 4 weeks before things are going to improve. And then by that stage, they would then safely be able to stop it for 3 days to be able to then have the screen. So typically with local estrogen, we'll say to use it every night for the first kind of 2 to 4 weeks, and then after that about twice a week. So you can usually then help people to time that to be able to have their screen.
Cervicitis, what does it look like, and can this also cause contact bleeding?
Well, that is a very well-timed question because the next slide is about discharge. And typically with cervicitis, it will be because of, you know, itis is inflammation. It will often be because there's an infection. So a cervicitis is effectively an inflamed cervix. Often there will be discharge. And so again, you know, it can depend on our practice, our confidence, our competence in terms of what we would do here, whether we'd be happy to be taking swabs, for example, talking to that patient about a sexual history, you know, thinking about whether any treatment was needed potentially. So this could well be a situation where you're going to want to talk to somebody and think about other things as well as your cervical screen. So with a cervicitis, often it will be quite red, kind of quite angry looking, and there'll often be quite a purulent discharge. If there's tenderness, that's really important that you chat with somebody that day. If the cervix is really tender, then we're potentially worried about PID, and that needs empirical treatment regardless of what the swabs say. But yes, with cervicitis, there can be contact bleeding because it can look really kind of quite inflamed and really quite sore. Anything you'd add to that, Collie?
No, it's just a lot of time the patient will explain how will present with pain and discomfort before you examine, and then you examine and go, there, I can see why. I can see exactly why. So making sure that you've got the right treatment and testing.
Yeah, absolutely. And you know, some of you will be really expert and used to doing that and have been doing that for a long time. Fantastic. And for other people, if they're quite new to this, it can feel really daunting, I know, to kind of think, what swabs do I do and what questions do I ask and what treatment do they need? And nobody's expecting you to do anything that is not within your job role. And so, you know, really important to recognise when you don't know and, you know, to speak to your supervisor about the next steps. Yeah. A couple of less common pictures. Cervical stenosis, we don't see that much. Very important to recognise if somebody potentially is wanting to have a coil fitted. Very useful to know if there's cervical stenosis before that. It's something that can be congenital, so sometimes it can be from birth. It can be acquired, so it can come on after, particularly treatments like radiotherapy, or if somebody's had a cone biopsy. If it's congenital, if it's something that somebody's always had, then they often, as they come to first start menstruation, will have a lot of discomfort because the blood effectively has nowhere to go, and so they would have what we call primary amenorrhea. Their periods may be late in starting. Obviously, that's not something you're going to see at 25 with the first smear, but just one of those kind of images that it's useful to have seen to give you potentially a sort of heads up as to what you might see on occasion. So certainly not common. And as I say, one acquired typically is after a treatment like radiotherapy.
You've got a question about cervicitis. Would you take the smear with the cervicitis? And I would suggest swabs, treatment, and then bring them back. The guidance is to do the treatment first, but if you don't think that they're going to return, then you can go ahead and do the smear sample at the time.
I think that is a really good approach. Yeah, quite individual, down to the patient. If it's somebody that, yes, who you've been desperately trying to get in for this appointment for ages, and yes, and they're already overdue on their screening and you're really not sure if they're going to come back, then just take it. But yes, if you're pretty confident you can get them back again, then yeah, I'd agree, Carly. Yeah.
Is it the same practice to use a brush when taking the sample for the stenosed Oz? And I believe you've got the two different brushes. So you do the normal sample, and if you can fit the, I can't remember, the more wired brush, and do one clockwise turn, if you can find any opening to the Oz, and send them off in the pot.
Brilliant. Yeah. Yeah, perfect.
Sam, sorry to interrupt. It's Kerry. It's your 15-minute warning.
Thank you, Kerry. Good. We're doing pretty well. This is my last image, and then we've got a couple of kind of closing slides, so there'll be lots of time for more questions and chat. This is a picture of endometriosis of the cervix. I've only seen it once, but you can get deposits of endometriosis around the cervix, and they have this classical kind of bluey black appearance. Almost looks a bit like a vein, that type of colour. But if you were to compress it, if you were to sort of hold a swab over that bluey black area, it wouldn't compress like a vein. Not at all common to see, but another useful picture. I just thought it would be worth popping in. So if you saw something like this again, I would suggest that that patient had a chat with the GP if they weren't known to endometriosis and potentially had other symptoms that could be relevant. And that's the only image that's not from that cervical chart. All of the others were, but again, I'm really happy to share the links to these slides so you can look at the references from the links. So I think we're up to date on questions by the look of it from the chat at the moment. Well done. So coming back to kind of where we started. So this is the nice CKS advice about when we should be thinking about referring. So an abnormal appearance of the cervix on examination such as an inflamed or friable appearance with contact bleeding, or a visible ulcerating or necrotic lesion of the cervix. And this is where I think the contact bleeding gets quite tricky, because, you know, certainly the visible ulcerating or necrotic lesion of the cervix, nobody's going to argue with that. That clearly is high risk for cancer, and we want all of those to be going through. There can be many different reasons for an inflamed or friable appearance of a cervix with contact bleeding, like the ectropion, of which, as we were saying, the vast majority won't be concerning. So our remedy guideline, I suppose, is slightly different to this kind of nice CKS guideline in terms of what we're doing around our worries. So again, interested in all of your thoughts on that, really. I'm not sure there's necessarily a right or a wrong answer. And I think, again, it comes down to our assessment and our worry level. That, you know, sometimes contact bleeding feels very significant, and other times it doesn't. Sometimes, you know, you look at a cervix and you just know it's going to bleed and bleed. And there are other parts of the story and other parts of the examination that are also worrying you. Other times the cervix actually looks quite normal, and there'll be a little bit of bleeding and there'll be nothing else that worries you. And in that situation, as a GP, I wouldn't be worried, and wouldn't think that person needed to be referred. But I know there'll be a big range, and there's not necessarily a right way or a wrong way. It all comes down to our personal worry level. So interested in people's thoughts on that, feel free to post in the chat what you do with contact bleeding, whether you have an approach that you'd like to share with others.
I think it's a really good opportunity, if you do have contact bleeding with no concerns, just to explain what's going on. And also it gives them an opportunity to have a conversation of, do you have any bleeding when you're not expecting to have any bleeding, any postcoital bleeding? Because some people may think that these things are normal and absolutely fine. Yeah. So it's a good opportunity to open up the questions.
Yeah, I think that's a really good point, Carly, that, yeah, there's not a lot of knowledge about the signs of female cancers out there. There's big campaigns ongoing at the minute about trying to sort of help people know about what to look for. A lot of women with postmenopausal bleeding, we know, don't come forward, and aren't worried. A lot of women with intermenstrual bleeding and postcoital bleeding, again, won't necessarily be coming to see us to talk about it. So yeah, it's certainly a good opportunity to just kind of triple check, right? Has this happened before? What's happening? Tell me about your bleeds. Do you get any bleeding outside of your period that's normal for you? And again, it can be hard, can't it? That if somebody's got a Mirena, sometimes their normal bleeding pattern is a bit all over the place anyway. So it can be difficult to assess sometimes whether to worry or not. So it is often not straightforward in terms of thinking about what's happening.
But I think if they do have a contraception that makes their periods irregular, and they're concerned, always worth just checking in with the GP to have a full history taken.
Yeah.
If you think that there's no worrying signs on the examination.
Yeah, that's right. If the bleeding can't be explained by what you've seen, there may well be another cause for that bleeding. That yes, we should be potentially thinking around.
So we've got a few comments. I find quite a few people do have contact bleeding, but no other concerns.
Yeah.
Bleeding, I check no abnormal bleeding, pain or discharge, or any sexual health concerns. If any concerns, may do swabs. Right. If concerns around STIs or any other signs, then refer to the GP. Sometimes I get patients who are due their period. Can it be common their bleeding starts from having the smear?
That's a good question. I don't think having the smear would bring their period on, but of course, if they are literally about to start, then it could happen. Yeah.
And then Judy said, I think it's important to be honest with the patient and be confident in saying to the patient that you prefer the GP checks if you're unsure of what you've seen or heard. And I think that's perfect.
Definitely.
I think that's safest practice you've got going there.
Yeah. And I do exactly the same as a GP. If I'm not sure, I have exactly that same conversation of just saying, look, I think this is okay, but actually I'm not sure, and I would really value a second opinion from a colleague. And people really respect that. Nobody's going to think badly of you. They're going to be really appreciative that you take the time and effort to explain that and to arrange that for them. So yeah, I would absolutely agree. Thank you for that. Yeah, it's so important, isn't it? Just sharing, I think. So again, this is from NICE and CKS. So really just kind of reiterating what we've said, clinical features of suspected cervical cancer, we're arranging that urgent pathway. We're not delaying referral because of a previously normal screen, and we're not delaying referral until after pregnancy. So this was really my kind of wrap-up slide, really, before sharing a few resources with you. It's just encouraging you to kind of just think about what we've talked about today. So obviously today it's quite theoretical. We're trying to look at pictures that help us think about what we're seeing, but these images on slides are different to what we're seeing in practice. But have there been any areas today where you think, oh gosh, actually, I've never seen a wart. I don't really know anything about that. Or, you know, I'm happy with polyps. That feels good, but I'm not so confident about ectropion. So just have a kind of little reflection maybe around what we've covered today and whether there's any areas that you want to maybe read a bit more about or look at some more pictures or to kind of chat to somebody within your practice about what you would do. Think about how confident you'd feel actually about explaining these findings to patients. I think that's quite useful as well, just to practice the patter sometimes of, you know, this is what I've seen, this is how I would describe it. And I think that can be useful as well.
I think the patients really do want the reassurance that there's no correlation to some of these concerns with cancer, because they're obviously coming for the screening for a specific reason. And also I tend to have a backup of certain websites that I text the patient with information if they're happy, that also gives them information about the condition that reassures them, but also explains it in a little bit more detail. I think sometimes people get information at the appointment and they kind of don't take it in all information. So to be able to refer back after the appointment is great.
Yeah, I couldn't agree more. It's a big source of anxiety for a lot of people, isn't it? It's a big deal coming for a screen. Some people will be really psyched up for this appointment and they just won't be hearing a lot of what you've said at the end. So that backup of something to look at when they've kind of come down again is really useful. Yeah, definitely.
Okay. If somebody has intramenstrual bleeding or postcoital bleeding, should we be taking their smear? Yes, we should be. Yeah.
Yes,
so take
absolutely.
the smear, you can do swabs if you're worried about anything, and refer to speak to the GP, I would necessarily say.
Yes, that's right. Take the smear, but they may also need other things. So yeah, just, you know, thank you for telling me about that bleeding. That sounds like it's something that we should be, you know, looking into and checking out with you. I need to get you booked in with my colleague. Even if the smear is normal, especially if the smear is normal. Yeah, really important.
Is HPV a sexually transmitted disease? So it's not a disease, it's just a virus. I normally explain it to them as a virus that's passed through sexual contact or through contact themselves, because I think there's a lot of stigma around STIs. And the last thing we want for patients to think is that they've caught something, when actually over 80% of women have come into contact with the HPV virus at some point in their life. And when we do the sampling, if it is that moment where it's detectable, then that's very few and far between.
Yeah.
And between their smears, it may be detectable multiple times.
Yeah, absolutely. I think it's really important we normalise it. HPV is everywhere, so I'm really conscious of the language I use when I talk with women about HPV. I say we. I include myself. I kind of, you know, say any of us who have had sex have probably been in contact with HPV. It is everywhere. You know, it can be skin to skin contact. As I say, it's not even penetration. You can have used a condom every single time you've ever had sex and still have HPV. It is normal. So yeah, it's just normal.
And
there
you
is a lot of stigma.
the sites, and to be honest, I have a good Google, find something that's reliable, NHS website, and make sure that it is clear and in a way that the patient can understand. So the last thing you want to find is information that is aimed at GPs or nurses, and then just make sure it's from a credible source.
Yeah, patient.co.uk I use all the time. I think that's, a really good one. It's all kind of really reliable. As you say, the NHS website is very good as well. But yeah, I quite agree.
Website since closed down, unfortunately.
It has, yeah. Joe's Trust.
All the time. That's it.
Yeah, Eve Appeal are very good. So they're the one who've got a campaign going at the moment around the 5 gynae cancers and kind of heightening awareness. They've got some good resources. And yes, talking of resources, these are some quite useful ones as well. Gateway C have got, webinar and some courses if you kind of want to do a bit more theory and a bit more kind of practice and a bit more understanding about cervical cancer. Those are useful. And the e-learning for health module, again, has got a quiz with some pictures that can be useful if you want to kind of, again, have a bit of a self-assessment of different images. I love the Beautiful Cervix project. You probably a number of you have heard about it. It's lots of women who have photographed their own cervix and shared the images. So it's an amazing resource for seeing just lots of different bodies, different normals. And there are kind of tags for things like polyps. So again, you can kind of see lots of different pictures. And of course, Remedy, good old Remedy, where would we be without it for all of our guidelines in terms of our local referral pathways?
And somebody's asking how close are we to self-swabbing for smears, and I believe there's a update coming very, very soon about cervical screening and some changes that are coming. I'm not privy to all that information. I've signed up for it and I'll share it again on the Facebook group, the WhatsApp group, the Microsoft Teams as well. And hopefully we'll get a bit more information. I don't know if you're able to say anything more about that, Sam.
Yeah, I agree. It's really exciting, isn't it? I think that could absolutely transform things for some people, particularly. As we've said, the purpose of today is not to talk about how to engage people with screening, but we know that for some people it is a non-starter actually to come to see us for this sort of examination. So a self-screen is going to be transformative, I think. And the results of the initial study seem to be quite promising. It is HPV assessments, so there will still be some people who will then need more investigations. But yeah, promising and encouraging to see this being done.
Especially catching the people that are too nervous to come in for their cervical screening, that would be quite happy to do a self-swab. I think we're up to date with our questions. Kerry's just put in the chat about feedback form. Any feedback would be gratefully received.
Yes, thank you. Well, amazing.